condition that is basal cell carcinoma of the skin. This disease is seen sometimes in the area that is paraoral, so not inside of the oral cavity, but rather in the area surrounding the oral cavity, and that's why it's included here. It is the most prevalent cancer of the skin, or the most common type of the skin cancer, as well as the head and neck cancer. It's also mostly seen in older patients on non-hair bearing skin, like the skin of the face, skin of the nose, vermilion border of the lip, and so on. So the areas in the skin that do not bear hair. Men are, again, affected more than women. This may be attributed to greater cumulative sun exposure, even though this is changing now, because now all the men and women are exposed to the sun to a similar degree. Patients with lighter natural skin pigmentation have higher risk of getting basal cell carcinoma, and also the chronic sun exposure. So people with jobs or habits of being outside in the sun for longer periods of times might be vulnerable or at high risk for basal cell carcinoma. We also have several predisposing hereditary syndromes. One example of that is NBCCS, which refers to nevoid basal cell carcinoma syndrome. If the patient have this syndrome, they might be at high risk of getting basal cell carcinoma. So those patients will have multiple odontogenic keratocysts. They will have skeletal abnormalities. They have numerous basal cell carcinomas. If you find the patients with one of the features, you have to check for the others, just to help the patient get an earlier diagnosis. So clinically, the basal cell carcinoma is seen as an indurated pearly papule or a nodule with telangiectatic vessels coursing over its surface or crossing over its surface. It's like a pearly nodule with very tiny blood vessels across the surface of the lesion. The center of the tumor might become ulcerated and crusted, as we can see in the picture at the bottom. And basal cell carcinoma is not an aggressive disease. However, if it's untreated, the tumor exhibits a slow, relentless, locally destructive nature. So it is not an extremely dangerous or aggressive disease, but if you let it go without treatment, it is chronic and slow growing, and eventually it destroys the local structures quite much. And you can see the difference between this initial lesion here, it's quite small, and this one, it looks like an advanced lesion. So the patient has not been treated until it's basically destroyed this part of the face or the nose. The histology is quite different from the histology of oral squamous cell carcinoma, in which we can see single cell infiltration. The basal cell carcinomas, usually it's found in nests, very large nests or islands, sometimes cords of cells that are cuboidal rather than squamous. So these cells now are a little bit different in shape. They are cuboidal. They arise from the region of the epidermal basal cells. You have to remember that this is a skin carcinoma. It's not a mucosal carcinoma. So now we are talking about epidermis here. The epidermis contains basal cells. These are the origin of the basal cell carcinoma, hence the name. The neoplastic cells are usually palisaded, so they change the orientation of their nuclei, and they are often columnar or elongated, a little bit elongated in shape. And infiltrative nests are found in a fibroblastic stroma. They are carried by a fibroblastic stroma. You can see it here. The light pink, this is the stroma that we're talking about. And these purple islands are the basal cell carcinoma invasion happening. So how about the treatment and the prognosis? Because basal cell carcinoma are generally slow growing and they are rarely metastatic, the prognosis is very, very good, actually. So if you catch them on time, they can be treated and they do not metastasize and they are very slow in growth. There are various surgical procedures to take care of the situation, like standard scalpel surgery, you have cryosurgery, you have electrosurgery, and you have most microscopically guided surgery. These are different surgical techniques. Also, irradiation can be used in some cases. And the type of the treatment, usually remember that the type of the treatment depends on the size, the location of the neoplasm, and the general health of the patient, as well as the experience and training of the clinician who is performing the treatment. This example here shows Kim Benz. This is a patient who is a regular tanning bed user since her teens. She was diagnosed with basal cell carcinoma in her early 20s. She was actually lucky. Look at this pimple here. Anyone would think this is just a pimple, it will go away. It didn't go away. So she was smart enough to examine it or to check it, and it turned out to be cancer, but she was lucky. It was removed and she got out of the disease with minimal damage, we can say, because if it went untreated, it might damage the entire face of the patient. The final example that I want to mention today is verrucous carcinoma, also known as sniffer's dip cancer or Ackerman's tumor. Ackerman's, according to the scientists who described the disease, verrucous carcinoma due to the appearance of the lesion, and snuff dipper according to the cause of the problem. So the primary cause is suggested to be tobacco, especially smokeless dipped tobacco, like the tobacco that is used in Sudan. 5% of all intraoral squamous cell carcinomas are verrucous carcinomas. Clinically, it is seen in the buccal mucosa in more than 50% of the cases, and in the gingiva in about 30% of the cases, especially mandibular gingiva, and it affects males over the age of 50. These are the predominant group of verrucous carcinoma patients. So it's relatively superficial and it appears white due to the large amount of keratin present in it, and it does not invade to the inside. It rather grows to the outside. So it has an exophytic growth like a plant coming out of the ground. It may arise in leukoplakia or be preceded by leukoplakia, which is a pre-malignant condition that we talked about in lecture number 2. But sometimes it might just grow de novo, so not preceded by any pre-malignant lesion. The lesion borders become irregular and indurated with the time passing, and then exophytic with a whitish gray surface might be seen. It is locally destructive, but it rarely metastasizes, which is the good news. But however, it destroys the tissues that surrounds it in the close vicinity. So this one here is seen in the upper jaw, in the alveolar ridge. The lesion is quite massive, and you can notice the surface and the roughness of the appearance and the exophytic growth. This one here is seen in the tongue. It's completely white. It means there is a very large amount of keratin. Keratin is seen as white color to the naked eye. Under the microscope, it is red because it picks up the reddish stain of H&E stain. So the appearance is quite typical for the verrucous carcinoma, but remember, we have talked about verrucous and other verrucous conditions. You have to make sure that verrucous carcinoma contains the specific histological hallmarks in order to diagnose it. They are quite specific. So it has a markedly acanthotic and thick and highly keratinized epithelium and epithelial surface. So the highly keratinized part, we just saw it reflected as a white color to the clinic. And under the microscope, I just mentioned, it is quite red or deeply pink. And the epithelium is quite thick, which means acanthotic. So the second hallmark here is the bulbous, well-differentiated epithelial masses extending into the submucosa with blunted and pushing borders rather than invading individually or in islands. So you will not see islands. The basement membrane will not be cut off. You will just see a pushing border. So imagine a team, or a football team with 11 players pushing a wall and moving it from its place towards another place. This is the way that this tumor invades. It does not invade with individual or small groups of cells. It rather invades by pushing and covering the connective tissue area. You will see a picture in a little bit. The third feature is the presence of lymphocytic infiltrate. The lymphocytic infiltrate is a chronic inflammatory cell with some focal areas of acute inflammation, which has neutrophils and other acute inflammation cells. So lymphocytic infiltrate, pushing borders, and acanthotic, highly keratinized epithelium. The fourth feature or hallmark is the benign microscopic pattern. Even though this is a malignant tumor, it does not appear as malignant. It shows completely benign microscopic patterns. There is absence of significant cellular atypia and pleomorphism. So you will look at the cells, they will appear quite normal to the eye. They are, however, part of a malignant tumor. So these four hallmarks are the diagnostic features of verrucous carcinoma. Let's look at the picture here. You see the quite thick appearance of the epithelium. It's quite thick. It's highly keratinized. This color here is the keratinization. You can see it's white color in the picture, but it's red in the histological appearance. The border is continuous and it's pushing. So it's blunt and moving all together as a unit. The connective tissue is infiltrated by lymphocytic infiltrate. You can see the dark dots found in the connective tissue. And if you zoom in, there is no sign of atypia, so the cells look quite normal or very close to normal. And these are the features that will determine the diagnosis for you. However, it can be mixed up, or you can misdiagnose it with other. It is not completely unique. Differential diagnoses include well-developed cases. So in the well-developed cases, you don't need to consider differential diagnosis. It's a straightforward diagnosis. Otherwise, if the case is not very obvious, it looks very much like leukoplakia. It looks also as papillary squamous carcinoma, but the papillary squamous carcinoma is more infiltrative. So it does not have a completely pushing border. It has more infiltrative appearance. The treatment of verrucous carcinoma is surgical removal. This is the primary form of therapy, is to remove the lesion by surgery. Sometimes aggressive radiotherapy, early or in combination with surgery, might also help. The prognosis is excellent, primarily because of its high level of differentiation. So it's not quite aggressive. The cells are not completely transformed. And it is rarely metastatic. It does not spread to distant spaces, it's only confined to the area of the origin, which makes removing it much easier than to chase the metastasis. Finally, I just want to show you these diagrams here explaining a little bit of difference between the tumors in this we discussed today. So this is the normal epithelium, keratin on top. The epithelium thickness is quite normal. You have connective tissue underneath. So if the thickness of the epithelium started to increase with no other change, this is called hyperkeratosis or hyperactivity of epithelium. If the surface started to become roughened with a lot of keratinization, this is called verrucous hyperplasia. We still are on the safe side. From here, we might end up with verrucous carcinoma, which is quite exophytic with a pushing invading border, or of the surface is more or less not very exophytic, but the lesion is invading individually or in small islands. This might be squamous cell carcinoma. So this will only help you imagine a little bit the difference in pathogenesis or the difference in behavior between verrucous carcinoma and squamous cell carcinoma. By this slide, I will end my lecture today for this series of epithelial pathology. If you have any question or any something that you don't understand or any comment on these lectures, please write down your questions. We will talk to each other in the live session determined by the organizers. Inshallah, you can ask your questions and I hope I'll be able to answer them. But you can also do your further reading from the books that I will put at the end here. They will help you a lot to understand the malignant tumors of epithelial origin in the oral cavity. I thank you very much for listening to me and I wish you a good night. Thank you very much.